Hello, everybody. My name's Ketan, Dhatariya, and I'm a diabetes consultant here in Norwich. I'm sorry I can't be there with you, and of course I thank Wissam and the other team who invited me to give this presentation. So this is what I was asked to talk about. What is the role of the endocrinologist in the management of diabetes-related foot disease? So it's a fairly short presentation, but I'll try and capture what it is that I actually do, what I try and do with as a member of the MDT here in Norwich. So let's talk about epidemiology to begin with, and you will have seen most of this data already. If not today, then in your reading, I'm sure. So the diabetic foot is a major global problem. And as you can see here, that every year about 4 million people will develop an ulcer of some sort. And I'll go into why that's important as I go through my talk. You can see that in the UK, it's been estimated that about £1 in every £125 spent in the entire NHS is just spent on the management of the diabetic foot. It is an enormously expensive problem. If you look here, that it is not DKA, it is not severe hypoglycemia, it is not HHS that is the most common diabetes specific cause of an acute hospital admission. It is the diabetic foot. And if you spend enough time at the NNN, you'll realize that is actually true. And you can see that people with diabetes are hugely more likely to lose a limb compared to people without diabetes. And of course, the vast majority of amputations are preceded by an ulcer, and it's been estimated that at least 80% of ulcers can be prevented. Of course, proper care can be, as I've mentioned, can reduce the rate of amputation significantly. And globally, it's thought that at least one limb is lost every 20 seconds due to somebody having diabetes. But there are some more foot facts. Only 50% of ulcers will heal in about 6 months, and that's with fantastic podiatry care, optimal offloading, antibiotics, revascularization, anything that's needed. Only 50% of people will recover. Unfortunately, 1 in 12 people will require an amputation, either minor or major, and reulceration rates are enormous, and that's despite good control of their diabetes, good podiatry care, having bespoke footwear and so on. You have to remember, it's what gets that person there in the first place, the lifestyle that they've led to allow them to develop an ulcer still there for the vast majority of people. And of course, if they have ulceration, the biomechanics of their foot will change and will also lead to increased risk of having amputation. And you can see here that it's been estimated that 1% of all people with diabetes will have an amputation above the ankle at some stage in their life. But it gets worse, and these are data from Andrea Ix, who's a health economist I'm currently working with, who's based in Düsseldorf, and she's currently the chair of the European Association of the Study of Diabetes Health Economics Group, which I now co-chair. And her data has shown that if you've had an ulcer, you have a 17% chance of dying within a year just by having an ulcer, not anything else. So it's a large problem. And of course, you don't die of your ulcer. You die of the vasculopathy the ulcer just represents, because it's a systemic disease. They die of their cardiovascular disease. They die of infection. They die of having diabetes and other diabetes-related complications. But just having the ulcer is a marker of premature cardiovascular mortality. But if you have an ulcer, then you've got a 10% chance of losing a leg. Okay, sorry, I apologize. It says if you've lost a leg, you've got a 10% chance of dying within a year. And again, it's not because of the result of the amputation, it's the result of their underlying vascular disease. If you have an amputation, then your chances of dying at 3 years are 50%, 50% chance of being alive, and a 70% chance of being dead within 5 years. So having an ulcer, having an amputation it's not a light undertaking, because of course you're thinking about the quality of life that these people have. You recognize that a large number of these people will be dead, and so therefore why are you doing this amputation? Is it going to change their quality of life? And of course the answer for many of them is yes, because they've either got an infection, they've got pain, they've got any number of different things that require them to have an amputation. But actually, you need to understand that even with the best standard of care, so aggressive management of their cardiovascular risk factors is still going to result in a large number of them being dead in a very short period of time. And these data put this into perspective. These are data from David Armstrong, who, for those of you who don't know, is a very well-respected individual in the world of diabetic foot disease, to show that actually the mortality from foot disease is worse than many, many cancers. And you can see here that if you have a foot ulcer, then your chances of dying are higher than somebody who's got breast cancer, for example. And overall, it's very similar to overall cancer mortality rates. And therefore, we all know that if you've got a suspected cancer, there is something called a 2-week wait, because you want to be seen quickly, because you know the mortality is worse if you're seen if you're delayed being seen. And that's exactly the same if you've got somebody who's got a foot ulcer. And there are data which I'll show you from the National Diabetic Foot Audit, which shows exactly the same. The longer that it takes for you to be seen by somebody who is expert in managing foot disease, the less likely you are to be alive and ulcer free at 12 weeks or at 6 months, and more likely to die overall. So the question is, what do I, as a diabetes doctor, actually do with a diabetic foot? And that's an interesting question, because in putting this together, it's actually been quite depressing for me to think, well, actually, what do I do? So, of course, I manage the glucose. But you have to remember, as I mentioned, the reason that they are in my foot clinic is because they've lived a life over several years to get them to where they are. And that, of course, is likely to be people who haven't had the best diabetes control for most of their life. They haven't had their blood pressure controlled. They haven't had their lipids controlled. Many of them continue to be smokers. And so, therefore, the risk factors for developing peripheral arterial disease include poorly controlled diabetes and all the things I've just mentioned. So what do I think I'm actually going to be able to do for them in the time that they come to see me? Am I going to change all of the things all of the modifiable risk factors? And the answer is, I recognize, is unlikely to be the case, but I can do my very best. And so I have a holistic approach. We look after their diabetes, we look after their blood pressure, we look after their lipids, and if we can, we try and look after their weight. In people who've got type 2 diabetes, who make up 70% of the people I look after, I can often give them medication that is associated with significant weight loss, in addition to improving their diabetes control. So those are the GLP-1 analogs and the SGLT2 inhibitors. Of those drugs, I tend to avoid canagliflozin because of the increased amputation risk from their original cardiovascular outcome trial, although that is also challenged because the amputation risk in the placebo group was half that what would expect. But anyway, that's beside the point. So I tend to use a lot of GLP-1 analogs. I tend to use a lot of SGLT2 inhibitors in my clinic, because I want to improve people's diabetes control, because I want to get their weight down if I can certainly get it, in addition to the statins, the blood pressure, and the glycemic control, as I've mentioned. But there are a very large number of things that I have absolutely no influence over. And I'm going to show you some data in the next few slides from the National Diabetic Foot Audit. So these are data which show what are the most important factors that determine whether somebody is alive and ulcer-free after they present with their ulcer. And the size of the circles represents the degree of contribution that factor has into that person being alive and ulcer-free. And you can see by far and away the most important thing is whether they got peripheral arterial disease and ischemia. The next few things there, you can see the ulcer size, whether it's deep to bone. As I mentioned, the time to first expert assessment. There's an enormous relationship between presenting to primary care with an ulcer and for the primary care to then refer to the specialist diabetic foot clinic. I've not shown you all of the data, but this is huge, and that is a modifiable factor, and therefore we spend a lot of time educating primary care teams to say, if you see somebody with an ulcer, you get them referred to the specialist foot clinic, because we want to make sure we can do something about it. Don't sit on it. Don't just give them flu clocks. Don't just say rest your feet. Get them seen by the foot clinic, because we can help determine what happens to them. The number of ulcers, whether they're infected, and of course that's something that I can potentially do, because we have an award-winning antibiotic protocol at the Norfolk and Norwich, which is shared, which can be shared across the country, and is actually been referred to by NICE as an exemplar of what we can do to treat people. Where it is, whether they've got neuropathy, of course, and again, that's how they've managed their diabetes over several years before they get anywhere near a foot clinic. How long they've had diabetes, of course, nothing we can do about that. Whether they've got a Charcot, again, that's about education and people who've got neuropathy and foot disease. Whether they've got heart failure, what their gender is, smoking, and so on. So what you can see in all of those things is there's nothing to do with modifiable risk factor optimization. Okay, you can't, there's nothing I can do to say, well, actually, if you stop smoking now, you'll be alive and ulcer free in a few weeks from now. It doesn't work like that. Glycemic control doesn't make a blind bit of difference. Lipid control doesn't make a blind bit of difference. So what is it that I'm doing? Well, I'm not looking after their ulcer at the time. I'm looking after the holistic approach to ensure that they actually try and live for longer. So what is it that a diabetes doctor actually does, according to this slide? Well, not very much, which is a bit disappointing for me. It goes into that data in a little bit more detail. So what you've got here is a forest plot. On the right-hand side is you've got all of the possible modifiable risk factors and what makes things less likely or more likely to be admitted. And you can see here that if you've had diabetes for a lot longer, you're less likely to be admitted. If you're a smoker, you're more likely to be admitted. Time to first assessment, if it's delayed, it's more likely to be admitted. If you're a bloke, it's more likely to be admitted, and so on. So you can see there are a large number of things that do have an impact in having the likelihood of being alive and ulcer free. And this is the next slide on what is it that influences admissions. And again, you can see by far and away the biggest contributor to admissions is the presence of ischemia and how deep the ulcer is and whether they're infected and how large they are. So I can't have any influence on that as a diabetes doctor, so I freely admit that those are not in my gift. Similarly, I can't affect somebody's age. I can't affect whether somebody's got heart failure at the time. Of course, that's trying to prevent them from having in the first place. And of course, that's something that I can do with the use of SGLT2 inhibition, which is now licensed for use in people without diabetes, also with heart failure, of course. And the number of ulcers, and you can see the other things there, again, none of which I have any influence over if they already present to me with an ulcer. It's all about prevention from my point of view, but you know, that's a bit by the by. So these are again that same forest plot. What are the things that influence admission? And you can see the things towards the right of the line of unity, predominantly in red, are those things that have are more likely to result in an admission. And it's all the common things: having an infection, the ulcer size, ischemia, the number of ulcers, time to first presentation, the presence of heart failure, and so on and so forth. Things that would be potentially intuitive. So I've stolen this slide from Catherine Gooday, my senior podiatrist, and you can see these are the things that we talk about when we talk about the holistic approach. So it's talking about metabolic control, which is what I talk about all the time, getting on top of the infection by using appropriate antibiotics, offloading, which my podiatry team are very experienced at, vascular control, which is what, of course, you guys do, wound control, which is everybody, it's predominantly debridement using either in theatres or in the clinic, and education, which is what my podiatry team do all the time. So where do I fit in? Well, not very much. I don't think I actually probably do very much. So I just put my feet up, and I don't actually do very much. And as I say, I manage their diabetes, their blood pressure, their lipids, their weight. I manage simple osteomyelitis wherever I can. I give them prolonged courses of antibiotics because that's what I can do, and I can look at their X-rays and I can determine whether it's working or not. And if it isn't, who I need to refer to, so either to the vascular surgeons or to David Loveday, the orthopedic surgeon. Of course, I manage Charcot predominantly, but most importantly, I call for help when needed. So in summary, ladies and gentlemen, I actually don't think diabetes doctors do very much when I look at it objectively, but I like to think I add something to the team, and I'm always there if you need me. So with that, I'll say thank you very much, and hopefully I can come to your aid as necessary.